for this wonderful opportunity to again catch up with you all, guys. I think most of my friends are from Kerala, and Kerala Ophthalmic Society is the one which I end up attending more often than the Karnataka Ophthalmic Society conferences. But well, thanks to you all. So I'm going to start my topic with a few mistakes which we commit, which we all commit in our dry eye management, and I'm going to take one by one. These are the things which are not, I wouldn't say a mistake, but that's related to the misconception in our entire science of dry eye. And I call dry eye science a very skewed science because the way we define dry eye is very, very different. So let's start with the first one. First is the classification of dry eye into aqueous deficient and evaporative dry eye. Whether it's due to which ultimately defines it as an aqueous deficient or evaporative, or whether it's an Asia Cornea Society, which ultimately again ends up classifying into aqueous deficient or the evaporative or poor wettability, what they call. All these things, they basically defining dry eye into two major components, aqueous deficient and evaporative. But by doing this thing, are we actually classifying dry eye based on the root cause or just the effect? And unfortunately, we are doing the classification based on the effect of the disease and not the root cause of the disease. If you look at the dry eyes, do you think the dry eye which is related to a rheumatoid arthritis would be same as dry eye related to MGD just because their Schirmer's values are equal and low? Well, of course not. We know that. Shouldn't we be treating the root cause and the root problem and not the effect? Well, unfortunately, in the dry eye, when we call signs of dry eye and when we see the damage has already occurred and it's already irreversible damage most of the time. If we look at an example of GVHD. Now, GVHD typically occurs with the allogenic stem cell transplant on bone marrow transplant. And according to one study, more than 60% would end up in dry eye. But in my experience, where I closely work with the bone marrow transplant unit, most of the patients at some point of time in their life, they do end up in GVHD. So the problem is that in spite of very high probability of dry eye due to the GVHD, we would not call it a disease or we would not call it dry eye till we see the sign of damage. And when we see the sign of damage, we will tell them that, you know what, the dry eye because of the damage to your lacrimal gland is irreversible and will not be able to do anything. Whatever is lost is lost. So that means we waited for it to get damaged and then we are telling them now it is damaged. So you think about a person who has undergone bone marrow transplant, comes to us, and we'll look at his surface and we'll look at the Schirmer's value, you look at everything and you will tell them, you know what, there is no damage, so you don't have dry eye. But we know that by the time you see the damage, it's already lost game. So such kind of cases, wherever we know that there is certainly going to be an inflammatory damage, like as I described, allogenic bone marrow transplant, somebody with autoimmune disease, somebody with Sjogren's syndrome, thyroid dysfunction, OCP, such kind of cases, the dry eye, which is going to be inflammatory dry eye, we must start anti-inflammatory much before we see the damage. And all these anti-inflammatory, we know whether it's a cyclosporin or tacrolimus, they have very wide therapeutic window and hence we can safely start them. Coming to the mistake number 2. The most important test for dry eye diagnosis is Schirmer's test. Most of the time when we get a referred case, we get like Schirmer's normal, Schirmer's that too without anesthesia. And Schirmer's normal value does not actually mean anything to me. Frankly speaking, there is certain thing which we, even if we look at the diagnostic criteria, most of the dry eye diagnostic criteria confirms that the gold standard is questionnaire, quality of vision, BUT and Schirmer's test. But if you look at any of these things, are we actually able to find out the root cause or we are just seeing the effect? And unfortunately, we are just seeing the effect. So none of these things actually tell us about the root cause. So what are we doing to look at the effect? Well, very interestingly, the Asia Dry Society came up with a pattern of tear film breakup time, which had some correlation with the disease. Whether you have some particular type of pattern, whether it's an area break or whether it's a spot break, which is related to operative dry eye, or area break, which is related to severe aqueous deficient dry eye, or linear break related to aqueous deficient dry eye. But that's very interesting. The test is very simple, and we surely can introduce in our clinical science. But is it so repeatable in every society? Unfortunately not. Our eyes do not always show such kind of pattern, but that's very interesting part, that not just Shermer's test, your tear film breakup time is something which is very, very important, and we do not give that as importance as we normally should have given. Mistake number 3, the frequency of lubricant 4 times a day. Somehow we all ophthalmologists are tuned to give every lubricant 4 times a day. There's no logic behind that. Now the question arises, how long a drug stays on the ocular surface, and that's called ocular surface resident time. And that depends upon the rheological property of lubricant, that's viscosity, the blink rate of the person, the temperature of ocular surface, the pH of the surface, as well as the lubricant, the tear film clearance time, the absorption of lubricant on surface, as well as the evaporation rate. And you know that every individual, these things would not be same. So a different individual, a same lubricant may not have same amount of ocular surface resident time. Interestingly, from Anthony Braun's group, they had done very good study on ocular surface resident time especially related to the artificial tear solutions. Using direct and indirect method, they measured the half time. Please remember that the complete time cannot be measured, because at the end of the fag end of the time where the molecule is on surface, it may not be in a decent amount to detect, or it may not be even effective enough that time. So usually we talk about the half-life. Now, the half-life of very viscous lubricant, what we are told now is sodium hyaluronate 0.2%, was 5.5 minutes. And that means even if you double it, which is not true, that the total time would not be more than 10 minutes or 15 minutes. And this is about sodium hyaluronate. Something like HPMC is 44 seconds. And if you look at such kind of lubricant, if you give them 4 times in a day, tell me, how do you expect any improvement, which is absolutely absurd according to me. Whenever we give anything which is 4 times a day, to me it's more psychological. If you have to give somebody lubricant, give more frequently, and need not to be exactly hourly. I mean, it need not to be exactly 2 hours on your watch. Well, it can be more often when they are doing some attentive activity or their high risk activity. Later on, they can have less frequent. So let's not be rigid in terms of the frequency, but let's remember that giving 4 times a day lubricant is actually totally useless. Mistake number 4, benzalkonium chloride or BAC. We love to hate this guy, and this is the best villain we have in our ocular surface. I do agree that it is severely surface toxic or epitheliotoxic, but when you're using a drop which is 4 to 6 times a day, it hardly matters. And also somebody who has a decent ocular surface or tear film turnover, within 30 seconds, it would dilute 8 times, and within 1 minute, 16 times, and within 3 minutes, it's diluted 36 times. I mean, it's hardly anything there on the surface. So if somebody's ocular surface is already damaged, or they are on multiple medication, or they have punctum occluded, in those cases, yes, I agree. But if you are using a drop which is 4 to 6 times a day, well, it's not as bad as we think. But of course, I don't say that we must use benzalkonium chloride, but preservatives are not as bad in your routine scenario. Mistake number 5, lubricants must have all the electrolytes, and we keep on getting new drops which tells us that we have every electrolyte possible. What are the use of these electrolytes? Well, these electrolytes, something like sodium, which is very important for maintaining osmolarity. Potassium is important for the health of goblet cell and glycogen. Bicarbonate is essential part of maintaining the epithelium integrity as well as the health of the epithelium, and it helps in healing. But unfortunately, this bicarbonate is unstable compound, and especially when you are using multi-dose vial, the bicarbonate gets converted into carbon dioxide, and which does not stay there long. So in multi-dose vial, bicarbonate does not help you much. Look at the sodium part of it. Now, when we say sodium is required for our osmolarity, remember one thing, the increase in the sodium level does not mean it's going to be better. In fact, the study with carbomer and sodium combination found that increasing sodium actually reduced the viscosity of carbomer. So just increasing addition of a saline in the treatment, some of the ophthalmologists, especially in countries like Japan, they like to use isotonic saline as a hydrating agent, but unfortunately not always that helps. Mistake number 6, higher viscosity, better the lubricant. And this is something which we love to talk about. Anytime, whenever we talk about lubricant, we talk about the viscoelastic agent, but that's just one part of the lubricant. What does these things do, viscoelastic agent? Well, it actually increases the surface retention time. Higher molecular weight will lead to longer retention on the surface, but as I discussed earlier, there are many other reasons why it should stay on the surface or it should not stay on the surface. But higher molecular weight can also have crusting, which can lead to foreign body sensation when those crusts fall inside the eye. The lower molecular weight may be less viscous, but remember, somebody who is just mildly symptomatic might be actually more comfortable with low molecular weight viscoelastic agent than very high viscoelastic agent. So always higher viscoelastic agents are not best. Now, the viscoelastic agent, when we talk about, we like CMC and all those things, but because of the price control in our country related to CMC compounds, now every company is pushing the compounds like PVAs and polyols and all those things back to us. It's more of an industry related push. But remember, like some of the compounds like polyols, they are natively not as viscous unless they're combined with HPGR. We'll look at them later on. Mistake number 7, not telling patient to refrigerate the lubrication. Now, why does require to be lubricated? Remember, the viscoelasticity or viscosity also depends upon the temperature. More the temperature reduces the viscosity. Certain agents like carmelos and hypermelos, they do not have enough viscosity at even your normal body temperature. And things like sodium hyaluronate or even CMC, when the temperature increases, and especially countries like us where we have temperatures in our ambient temperature can be like in 40s or something, the viscosity of such agent can significantly go down. So simple suggestion of asking them to refrigerate these compounds can actually maintain their viscosity, can increase the ocular surface resident time. The next mistake, combining different lubricant. Just to give an example, I'm using Cysteine Ultra name, but I do not have any disclosure here. Now, combining something like Cysteine Ultra with aminoglycoside cyclopentolate. What I mean by here is now I'm referring to pH part of it. As I discussed earlier, the pH is also something which decides the ocular surface resident time or effectiveness or the viscosity of the drop. Now, something like HPGR, which is integral part of the viscosity of something like Cysteine Ultra, the HPGR is liquid when the pH is acidic, and when the pH becomes basic more than 7.5, it becomes gel. The antibiotics like aminoglycoside, they only work when the pH is acidic. So if the effect of antibiotic has to be there, the pH of the surface has to be acidic, and that's why these antibiotics are acidic. So if in the case of conjunctivitis or in the case of microbial keratitis, if you combine these two together, either your antibiotic is not going to have effectiveness, or your lubricant may not have the viscosity. So combining such medications may not be the best thing. So which are the other medications which can have acidic pH? Cyclopentolate, very significant acidic pH. Tropicamide, ofloxacin, lead pitching, all those things can lead to acidic pH. And when you combine such kind of thing with something like Cysteine Ultra, well, you are not getting the viscosity of the medication. Hence, it may not be the best idea to combine these two. Some things like PVA, if they are mixed with certain gel, or sodium bicarbonate or sodium perborate, they end up having a thick, gooey material kind of thing, which is not very comfortable on surface and does not have very good surface coating time. CMC, when they combine with certain metabolites, so when typically multi-drug treatment, it can lead to insoluble precipitates, and more so with 1% CMC. So such kind of cases, we can avoid CMC when you're using multi-drug treatment. And as I said, HP guar does not remain liquid when the pH is less than 7. Next mistake we make is osmolarity, where we are taught that osmolarity is most important thing in terms of pathogenesis of dry eye, which is true. I do agree with that. But when we talk about measuring the osmolarity called osmometry, that's where our science falters. That when the osmolarity is checked on the surface, the range what we are told, the normal range is somewhere around 300 milliosmol per liter. But if you look at the normal data also, there's a huge crossover between normal and dry eye cases. So a case with the dry eye can have normal osmolarity, and case with normal eyes can have abnormal osmolarity. Also, on the top of that, the machine is pretty expensive. Also, if you look at the repeatability is very good when the osmolarity is normal, or the normal patient. But more the severe dry eye, the variability or repeatability is severely affected. If you look at the literature, there are interesting articles about dry eye being showing normal osmolarity compared to the normal cases. So dry eye osmolarity or normal cases osmolarity, both of them were same. Cases with Sjogren's syndrome or non-Sjogren's syndrome and normal, all of them, they had similar osmolarity. So osmolarity per se does not actually give you a diagnosis. Also, there are certain interesting things which we have to remember about osmolarity. The osmolarity is a dynamic thing. With each blink, the osmolarity changes and it varies in significant amount. The sample what we collect is from lower tier meniscus, and the osmolarity is not equal in entire eye. In fact, the most important place for us is the central part of cornea, where we do not measure. Most of the studies, when they have done ex vivo studies, they are not reliable. And even if we have hyperosmolarity, hypoosmolar agents, which were there earlier in the market, and as I told you, many surgeons, many ophthalmologists like to use isotonic saline or normal saline solution to hydrate the surface to reduce osmolarity. Interestingly, within a minute or two, this osmolarity comes back to the previous level as it was before the drops. So using hypoosmolar does not help you. So if I have to summarize the osmolarity, well, osmolarity is important thing, but increased osmolarity is important part of the dry eye, but unfortunately we are not able to measure it correctly. So we have to accept the hyperosmolarity per se. So how do you deal with that? Well, in that case, there are certain compatible solutes or osmoprotecting agents which are used by pharmaceutical industry like L-carnitine, erythritol, glycerol, trehalose. These things help you to reduce the cell damage on the surface of such kind of dry eye. Hence, even if the osmolarity is high, it can reduce the surface damage. So any of lubricant which you use, we wish that they should have osmoprotecting agents. We know about these osmoprotecting agents. So ultimately for osmolarity, well, we cannot deal with changing the osmolarity, but we can possibly deal with protecting our surface with osmolarity. Coming to the 10th mistake, every MGD should be treated with LipiFlow or warm compresses lead massage. Well, we know that meibography is something which is extremely important nowadays in treating the dry eye, especially the evaporative dry eye. The normal meibography shows vertical orientation of the glands, and in abnormal cases, you may see either convoluted glands or you may see loss of glands in some areas. I've been doing meibography since very, very long time using a simple autorefractometer where there were no Meibographers available. The autorefractometer with its infrared light gives you absolutely beautiful meibography. Unfortunately, you have to use your smartphone camera to capture that, but any IR source in that sense can be a help. Not all the machines are actually able to give you a good IR image to delineate the Meibomian glands. So you can try out different instruments in your OPD and you may find out something which works for you. Why is it important to measure the meibography? Well, the current practice, what we were taught, that when we see clinical diagnosis of Meibomian gland blocked or Meibomitis, we treat them with warm compressive lead massage. But when you check them with the meibography, and when you see the Meibomian glands are present, well, this thing is going to work. But when you check them, that if Meibomian glands are absent or there are loss of glands, even if you keep jumping on the eyelid, nothing is going to come out because glands are lost. In such kind of cases, whether we do LipiFlow or we do iLux or anything to express the Meibomian secretion, it's not going to help. So before doing any of such kind of thing, you must do a meibography. This is my own mother's meibography. I've taken her permission for this thing. She used to complain about severe dry eye, and I always, as we all do, our family members, that we don't give them too much importance, that, you know what, lubricant and all those things, till she came to me, and when I did her meibography and realized that she hardly had any Meibomian gland left in her either eyes. So such kind of cases, the best lubricant has to be something which is oil and water emulsion. And unfortunately, in the drop form, we do not have much option in our country. And hence, we may have to use paraffin-based ointment, something like Equilib PM or Cornigen in our country. Especially cases like Stevens-Johnson syndrome, when they have severe Meibomian gland loss, drop of or rather treatment with Cornigel or Equilib based on paraffin-based lubricant would be a life-changing treatment for them. I said 10, but well, who doesn't like a bonus? I'm going to just close down with a bonus, which is punctum plug. In our country, somehow we just don't like punctum plug, and where across the world punctum plugs are widely used. There is enough evidence in our literature which shows that with the punctum plug versus placebo, or rather punctum plug versus lubricant alone, there is significant improvement with symptoms, with Shermer scores, as well as TFM stability in favor of punctum plug. It's not just used for dry eye, it's used for PEDs, it's used for non-healing epithelial defect. Geeta said superior limbic keratoconjunctivitis, filamentary keratitis, along with refractive surgery, non-healing neurotropic defect, lid viper epitheliopathy, recurrent corneal erosion, contact lens intolerance, and somebody where you don't want systemic absorption of the medications. However, most important thing when we talk about punctum plug is sizing. If we do not do proper sizing, it's not going to help us. So basically, there are certain punctum sizes which are available. Now, we do have one such Vera punctum sizer, which is widely available in our market, India. So basically, it's like a like a rod kind of thing, or lacrimal probe kind of thing. which has on one side diameter which is 0.8, and the other side with diameter which is 0.6. So what happens is when you put a 0.6 plug inside, I mean 0.6 diameter rod inside, if it goes, if it doesn't go inside the punctum plug, that means the punctum is very small and you may have to use small size punctum plug. Then if you put the 0.6 and if it goes inside easily, then you turn towards the opposite side, which has a 0.8 millimeter in diameter. When you put it inside, if it snugly fits, well, you can go for the medium size and that's absolutely fine. But if the 0.8 also easily goes inside, that means you may need a larger punctum plug. And if you do not follow the sizing, you may have more chance of extrusion, which is the commonest thing where we do not like to use punctum plug. Most of the time, this is the flow chart which I would like to leave you with finally, where you have a patient where you think about doing punctum plug. First, do a lacrimal sac syringing. If there is any blockage of the passage, please avoid plugs. If the syringing is patent, you can use temporary collagen plug. These are very cheaply available. In fact, they can be as cheap as probably 100 rupees or so. And they're very widely available with us. So you can put a temporary plug and see the response. Usually they stay for probably 3 to 4 days time. And after that, if patient says that they had significant or he or she had significant epiphora, well, we may want to avoid the plug. But if patient was comfortable, you can use extended plug. Now, these extended temporary plugs are also quite cheaply available and which may work for almost 3 to 6 months. Different companies have different claims. Now, this significantly gives you a window period when patient can decide about the permanent plugging or not. If patient has any complication, well, you avoid it. If patient was comfortable, either you can repeat it or you can put a permanent plug. If patient has very severe dry eye, as Geeta was showing, a punctum cautery would not be a bad idea. So with this thing, I would close my topic. If there are any questions in comment, I'd be more than happy to take.